Good afternoon, everybody. We want to welcome you to our presentation on pancreatitis, and thank you all for coming and attending this afternoon. I'd like to first start by introducing our speakers for the day. We have Lori Sheffield, Sharon Brown, and Lynette Gray, and I'm Stacy Lowry. Like I said, we're just excited to get started on our presentation, so I'm going to actually get us started off. We're actually going to take a look at the objectives for our presentation today. By the end of the presentation, we would expect the audience to be able to verbalize the definition of pancreatitis with about 90% of accuracy. The audience will also be able to identify at least 3 risk factors associated with pancreatitis with about 85% of accuracy. The audience should be able to recognize 3 of the most common signs and symptoms of pancreatitis with 80% accuracy. And we would expect 85% of the audience to verbalize a general understanding of the pathophysiology of pancreatitis. Also, the audience will identify at least 2 diagnostic tests for pancreatitis with 90% accuracy. And the audience members will recognize the impact of the disease on the individual and family, as well as the ethical issues that are involved in a patient with pancreatitis. And we would expect about 85% of the audience to be able to do that. Also, 85% of the audience would be able to identify appropriate problems and plans of care that come along with a patient who has an illness such as pancreatitis. So, we get started off with what is pancreatitis. So, the definition for pancreatitis is simply the inflammation of the pancreas. While that's a very simple definition, pancreatitis is not simple at all. It's a very complex illness and requires a lot of treatment and a lot of monitoring to make sure the patients actually do well. With a lot of diseases and illnesses, you find that there's some great history that you can find out. Pancreatitis is not one of those. There's very little history on the pancreatitis at all, actually, but I was able to find a clinical description of acute pancreatitis that was first presented in 1652 by a Dutch anatomist named Nicholas Tull. He was very well known back in the 1600s, so much so that Rembrandt actually painted a painting called The Anatomist. The Anatomy Lesson actually is the name of the painting that Rembrandt painted on him. But not a whole lot extra history to find on pancreatitis. The incidence of pancreatitis is there are about 17 cases per 100,000 people in the United States, which is about 80,000 patients per year with pancreatitis. It usually occurs equally in men and women, and usually between the ages of 50 to 60 years of age. Risk factors. Obstructive biliary tract disease, or cholelithiasis, which is just gallstones basically, is a risk factor. Alcoholism is another risk factor that's associated with it, and actually about 30% of acute pancreatitis in the United States is attributed to alcoholism. Another big one is obesity. Obesity, of course, in the United States there are about 78 million adults who are obese and about 12 million children who are obese. And in Mississippi alone, that is about 35% of adults are obese. Peptic ulcers, trauma, and that can be penetrating trauma or blunt force trauma, such as someone actually having an accident and handlebars maybe even coming into the abdomen could actually cause the pancreas to become inflamed and cause a case of pancreatitis. Hyperlipidemia, smoking and certain drugs. Smoking was once thought to be a risk factor by association, meaning that a lot of people who drink alcohol also smoked. So they really thought that it was mostly associated with the fact that the person, was a drinker. They actually had high alcohol intake. But since then, there have been studies to show that actually smoking is an independent risk factor in itself, and they're not really sure why that is and what the cause or what smoking actually does to cause pancreatitis, but they just have been able to rule it as an independent risk factor now. And genetic factors such as hereditary pancreatitis and cystic fibrosis, and we know that cystic fibrosis patients actually have issues with pancreatic enzymes and digestion issues already. So those are actually the risk factors associated with it. And next we'll have Lori, who's actually going to present this section actually is going to be the pathophysiology of pancreatitis.
Acute pancreatitis is sometimes called edematous pancreatitis, and it's usually a mild disease. Acute pancreatitis often resolves spontaneously. However, about 20% of patients develop severe acute pancreatitis, which they usually do require hospitalization. Severe acute cases are typically necrotizing or hemorrhagic in nature. Acute pancreatitis develops because of an obstruction to the outflow of pancreatic enzymes caused by bile and pancreatic duct obstruction. One of the common causes, as Stacy said, that many people are familiar with for pancreatitis is due to gallstones. The obstructed ducts result in accumulation of pancreatic secretions and pathologic activation of enzymes within the pancreas. The activated intracellular enzymes cause autodigestion of the pancreatic cells and tissues, which results in inflammation and acute pancreatitis. This autodigestion causes vascular damage, coagulation necrosis, fat necrosis, and edema within the pancreas. In alcohol abuse, the ethanol is metabolized, which generates toxic metabolites, and that is what injures pancreatic cells. Chronic alcohol abuse can cause the formation of protein plugs in the pancreatic ducts, and of course that leads to obstruction. In severe acute cases, pro-inflammatory cells called cytokines they are known as the cell signaling molecules. They're released into the bloodstream, and this causes the activation of leukocytes, injury to the vessel walls, coagulation abnormalities in other organs such as the lungs and kidneys. Paralytic ileus and gastrointestinal bleeding can also occur. Translocation of intestinal bacteria to the bloodstream can cause peritonitis or sepsis. And release of these vasoactive peptides can cause vasodilation, hypotension, and shock. Okay, these systemic effects can lead to respiratory distress syndrome, renal failure, and systemic inflammatory response syndrome, which is known as SIRS. All of these are just a downward spiral for the patient, which includes severe sepsis, septic shock, multiple organ dysfunction, all which of course greatly increase the patient's risk for mortality and morbidity. As pancreatitis progresses, pancreatic fibrosis, strictures, and duct obstruction can lead to chronic pancreatitis. Irreversible structural or functional impairment of the pancreas can also lead to chronic pancreatitis. And then also commonly seen in patients with pancreatitis or pancreatic cysts. Chronic alcohol is the most common cause of chronic pancreatitis. Smoking and genetic factors also increase the risk of chronic pancreatitis. Some of the most common signs and symptoms that we see in patients is upper abdominal pain, which is caused by the edema that distends the pancreatic ducts and capsule. Abdominal pain that radiates to the back, abdominal pain that worsens after eating, and nausea, which could be caused by paralytic ileus, secondary to pancreatitis or peritonitis, and vomiting, which could lead to hypovolemia. Then also abdominal distension. It accompanies bowel hypomotility and the accumulation of fluids in the peritoneal cavity. The diagnosis is based on both clinical and laboratory studies. CT scans help determine the severity of the pancreatitis, and then in labs, elevated serum lipase is the primary diagnostic marker for diagnosing acute pancreatitis. Elevated serum amylase is characteristic, but does not help to diagnose the severity of the disease. In pancreatitis, the goal of treatment is to stop the process of autodigestion and prevent systemic complications. And included in this treatment is a short-term hospitalization, withholding foods and fluids to help decrease pancreatic secretions, and typically fluids are reintroduced within 24 to 48 hours if an ileus is not present. Narcotic medication may be needed to relieve the pain, and IV fluids are essential to restore blood volume and prevent hypotension and shock. NG tubes may not be necessary in all cases, especially with mild pancreatitis, but it does help to relieve the pain and prevent paralytic ileus in a patient who is nauseated and vomiting. And patients do experience an interruption in their ADLs due to the need for bed rest and pain control. Most acute cases of pancreatitis resolve after hospitalization and recover completely. The pancreas returns to normal with no long-term effects. In some cases, patients do have recurrence, which can lead to chronic pancreatitis. There is a greater risk for mortality in chronic pancreatitis if infection, pulmonary, cardiac, or renal complications arise. Chronic pancreatitis is also a risk factor for pancreatic cancer, which would also impact the patient's prognosis. Sharon?
Some of the costs related to pancreatitis. There are frequent hospitalizations for recurrent flare-ups. All patients with pancreatitis should be admitted to the hospital for treatment. They are given IV fluids for hydration, blood pressure maintenance, and replacement of electrolytes such as calcium and potassium. They may need to have surgery to clear an obstruction of the pancreatic duct of tissues or stones. Surgery may be needed to remove infection or dead tissue. There is a diet modification, which is they would need to be on a low-fat diet and actually frequent low-fat meals several times a day. Several medications may be needed. Antibiotics for infection, medication for pain management, pancreatic enzymes, which will replace the enzymes the pancreas use to produce to digest the fat and protein. The pancreas may not be producing the amount of insulin in the body that the body needs to regulate glucose. So as a result, the patient may develop insulin-dependent diabetes. There's a deterioration in the quality of life. There may be relapses or flare-ups. These patients are in a lot of pain, constant pain. Pain is also increased when they're eating or when they're drinking alcohol. There's weight loss because the pancreas is not digesting the fat and protein, which also leads to diarrhea. And these patients also are having nausea and vomiting. There's an increased risk for pancreatic cancer. And also they can have multiple organ system failure, which is a possibility of kidney failure or lung failure. How does pancreatitis affect their everyday life? Work, leisure, travel, relationships. They have a decreased physical activity related to pain and fatigue. They have psychological and emotional distress in how they view their own personal health. There are ethical issues related to pancreatitis. We as providers must omit personal biases. No judgment. Like he brought it upon himself. No one told him to drink all that alcohol for those many years. Pancreatitis needs to be treated with adequate pain medication because they are in a lot of pain. You are not there to judge whether or not they're in actual pain. Oh, he just drug seeking. Pain to that person is what they say it is and how they say it is, and it needs to be treated. We need to support these patients with pancreatitis, get them any information that will help them. The first step is by educating them. We need to educate the patient and the family on what to expect with pancreatitis and how to manage their care. Recommend Alcoholics Anonymous for those with a history of alcohol abuse. 70% of pancreatitis, especially chronic, is caused by alcohol abuse. Even if they drink a small amount, it can cause them to have severe pain. If they drink a large amount of alcohol, it can shorten their lifespan. The National Pancreas Foundation is a patient-based support group. They fund research, they advocate for new and better therapy, provide support for the patient, caregivers, and the healthcare professionals. And they also provide education. The next person is Lynn.
Good afternoon. I'm going to speak with you briefly regarding plan of care for acute pancreatitis. First, let's look at the problem list. You have acute pain, risk for deficit fluid volume, nutrition imbalance less than body requirements, knowledge deficit, risk for infection, diabetes, alcohol, abuse of alcohol, alcoholism, hypertension, imbalance in digestive enzyme, and social support deficit. You may be wondering what exactly is a problem list. A problem list is a list of current and active diagnoses. And most of the time this list is prioritized by what the patient come in the hospital with. It mainly would be the top 5 to 6 diagnoses which you would address. And that's normally what brought the patient in. A patient with pancreatitis, acute pancreatitis, would mainly come in with acute pain. They may be balled over in pain, and when they come into the emergency room, just complaining of abdominal pain and saying that it hurts really bad when they try to lay flat. And by saying that, when a patient comes in the hospital with acute pain, as Sharon stated, it's not our position to judge the patient or whatever. You should always try to give the pain in a timely fashion, because the longer you wait, as it states, severe and prolonged pain can aggravate shock and is more difficult to relieve, requiring larger doses of medication, which can mask underlying problems, and complication may contribute to respiratory depression. Maintaining bed rest during acute attack. You want to have your patient to be in a quiet room, quiet environment. If that means limiting the number of visitors they have or whatever can comfort that patient. In this acute stage, it would better benefit the patient to resolve this inflammation of the pancreatitis. Bed rest decreases metabolic rate and GI stimulation and secretion, thereby reducing pancreatic activities. Promote position of comfort. Most of the time the patient will say if they ball up like in a fetal position that relieves the pain a little, or sitting and leaning forward would also relieve the pain, because that reduces the abdominal pressure and tension, providing some measure of comfort and release. You may also offer a warm comforts to the stomach, provide alternate comfort measures such as back rub, encourage relaxation techniques, quiet diversion activities such as TV or radio. This promotes relaxation and enables patients to refocus attention, may enhance coping skills. You want to keep the environment free of food odors, because as we all know, if you ever been sick, nauseated, or what have you, the smell of food can make you more nauseated and have you throwing up or what have you. So to keep the environment free of food odors would be at the best interest of your patient, which sensory stimulation can activate pancreatic enzyme, increasing the pain. The next diagnosis would be risk for deficit fluid volume. Okay, so therefore, the doctor may order different IV fluid. It may be normal saline, albumin, blood product, or I think I read where lactate ringless is the medication of choice for acute pancreatitis. This choice of replacement solution may be less important than rapidly and adequately volume restoration. Saline solution in albumin may be used to promote mobilization of fluid back into the vascular space. Low molecule weight Dextran is sometimes used to reduce risk of renal dysfunction and pulmonary edema associated with pancreatitis. As I think Lori stated that a lot of the patients can get volume overloaded and have renal failure with pancreatitis. So checking their lab work and keeping an eye on the I's and O's to measure the intake and output would help you kind of keep that intact. That's basically what I was saying. Monitor the lab study. You got your H&H, protein, albumin, electrolyte, BUN, creatinine, urine oxalate, and sodium, potassium, and coagulation studies. Identify deficit and replace need in developing complications such as ATN and DIC. Okay, this is the same thing. Replace electrolyte with sodium, potassium chloride, calcium as indicated. Decrease oil intake. Excess losses greatly affect electrolyte and acid-base balance, which is necessary to maintain optimal cell and organ function. The third diagnosis is imbalanced nutrition, less than body requirement. A lot of the patients are, at this point in the acute stage, have not been able to hold any food down, so therefore they may be at risk for dehydration or what have you. And so with persistent in this can cause them to be less than body requirement. So at this point you need to assess the abdomen, noting present and character of bowel sounds, abdominal distension, and report of nausea and vomiting. This is due to gastric distension and intestinal autonomy are frequently present, resulting in reduced and absent bowel sounds. Return of bowel sounds and release of symptoms signal readiness for discontinuation of gastric aspiration. I think Lori mentioned that you could have an NG tube placed. It's not always necessary, but the patient would mainly be on bed rest. They would be NPO, and IV fluid are the main three things, including something for pain, for acute pancreatitis. Okay, provide frequent oral care. Of course, you know, if you clean your mouth and everything, you're subject to not stimulate whatever it is in your mouth to cause you to want to puke. Like we said about the odor, your mouth not being clean and everything can have you feeling the need to throw up. Provide frequent oral care decreases vomiting, stimulation, and inflammation and irritation of dry mucous membrane associated with dehydration and mouth breathing when NG is in place. Assist patient in selecting food and fluids that meet nutritional needs and restriction when diet is resumed. Okay, like I believe Sharon mentioned that it's a lot of, food that the patient needs to avoid, and you need to kind of educate them on that. The diet will change tremendously. They need to stay away from fatty food. I think you mentioned that, and also certain, they shouldn't consume a lot of white rice. Rice Krispies would be on the list. Things that they could have in the cereal category would be wheat. They can't have wheat, rye, and with the cooking oil, you need to recommend that they use. I did that vice versa, you all, I'm sorry. The wheat is what they do not need. You would have them to have white rice. Cooking oil, they would avoid corn oil and vegetable oil. So you would recommend soy, olive oil, or sunflower. I apologize for that. Meat, you would kind of stick with the standard. That would be chicken, fish, and stay away from fatty food and pork and beef. And they would be allowed to have fresh fruit and vegetables. Okay, previous dietary habits may be unsatisfactory in meeting current need for tissue regeneration and healing. Use of gastric stimulation such as caffeine, alcohol, cigarettes, gas-producing food like peas and beans and things of that nature, or ingesting a large meal may result in excess stimulation of the pancreas and reoccurrence of symptoms. Sharon mentioned that you should have these patients to have smaller meals several times a day outside of just watching what they eat. The amount of food that they eat would also have an effect on your pancreas. Observe the color, consistency, amount of stool, note frothiness, consistency, and bowel odor. This is because you may have that in your stool and that needs to be reported to the doctor. Knowledge deficit. You want to review specific cause of current episode and prognosis. You want to let the patient know where they are, where you anticipate they need to be, and where they're going to be if they don't follow the guidance of their doctor as far as eliminating alcohol and watching their diet and just dealing with things of this illness can bring on and cause a reoccurrence. So this would provide knowledge base on which patients can make informed choices. You want to discuss association factors such as excess alcohol intake, gallbladder disease. Some of the drugs that may be affiliated with this disease would be your Lasix, which is a diuretic that they need to be aware of could cause a flare and reoccurrence of pancreatitis. Avoidance may help limit damage and prevent development of chronic condition. Explore availability of treatment programs and rehabilitation of chemical dependency if indicated. It was stated that alcohol is the #1 cause of pancreatitis, acute pancreatitis. Therefore, you may want to recommend them to your local Alcohol Anonymous support group. And I think Sharon also mentioned a National Foundation for Pancreas that they could also be involved with to get more information regarding their condition. Alcohol abuse is currently the most common cause of reoccurrence of chronic pancreatitis. Use of other drugs, whether prescribed or illegal, is increasing as a factor. I believe Stacy mentioned that cigarette is now considered a risk factor in this disease, where once upon a time it was considered a just if you smoke, you may drink in that sense. So now it is considered one of the risk factors. Risk for infection. This is really more concerned. In the past, when you came to the hospital with acute pancreatitis, they would automatically put you on some form of antibiotic. They kind of really looked at that, depending on if you have surgery, if they feel like it's really inflamed and all of that, they may put you on antibiotic, and if so, the risk for infection is higher. And at that point, you should always stress the importance of good hygiene, good hand washing to reduce the risk of cross-contamination. Observe rate and characteristics of respiration, breath sound, note occurrence of cough and sputum production. This would indicate fluid accumulation and limit mobility, predisposed to respiratory infection, and accumulation of ascites fluid may cause elevation of diaphragm and shallow abdominal breathing. Encourage frequent position change, deep breathing, coughing, and assist with walking as soon as safe. Enhance ventilation of all lung segments and promote mobility of secretion. You want to, as soon as the patient is off of bed rest, which is normally 24 to 48 hours after being on medication and being treated for acute pancreatitis, you want to encourage them to get up, walk, and to get mobile. This would expand the lungs and have them not so at risk for respiratory infection and what have you. So always teach your patients good hand washing techniques, and that concludes our presentation. Are there any questions at this point? We would like to thank you all for taking time to come out and listen to our presentation. We hope that you did get some good information from this presentation, and by all means, if you have any questions once you leave here, please feel free to contact either of us. That's Sharon Brown, Lori Sherfield, Stacy, and Lynn Gray. Thank you again.